Welcome to our comprehensive PTSD treatment protocol, a 12-session journey designed to integrate cognitive, behavioral, and somatic interventions for trauma recovery. With sessions lasting 50-60 minutes, this evidence-based approach has shown significant effectiveness in clinical settings, reducing symptoms by 65–70% when properly implemented. Let's explore this transformative framework for healing. Understanding the landscape of PTSD treatment is crucial. Cognitive processing therapy focuses on modifying unhelpful beliefs related to trauma, while prolonged exposure therapy gradually confronts trauma memories to reduce avoidance and fear. EMDR therapy uses bilateral stimulation to aid in processing trauma memories, facilitating adaptive information processing. Our treatment planning framework is a roadmap to recovery, beginning with an initial assessment and safety planning. Psychoeducation helps in understanding trauma and building coping skills. Trauma processing involves specialized protocols, and integration consolidates gains, developing relapse prevention strategies. Session 1 focuses on comprehensive assessment, creating a trauma timeline, and using clinical measures to establish baseline symptoms. Comorbidity screening identifies conditions that may impact treatment, while safety protocols develop personalized crisis management strategies. In Session 2, we engage in psychoeducation and treatment planning. Collaborative treatment selection ensures the best approach, while goal setting establishes clear objectives. Trauma education helps understand its effects on the brain, and grounding techniques teach initial stabilization skills. Session 3 is about building emotional regulation skills. Understanding the window of tolerance helps recognize personal triggers. Breathing retraining and progressive muscle relaxation are key techniques for managing arousal states and reducing physical tension. Session 4 delves into the cognitive model of PTSD. Identifying trauma-related cognitions and gathering evidence to challenge these beliefs is crucial. Cognitive restructuring helps develop more balanced perspectives, while thought evaluation examines cognitive distortions. In Session 5, we begin EMDR Phase 1, focusing on client history and planning. Trauma mapping creates a sequence for memory processing, resource development builds psychological stability, and the safe place exercise establishes a mental sanctuary with bilateral stimulation. Session 6 prepares clients for EMDR Phase 2. Bilateral stimulation demonstrations, stop signal practice, and SUD scale training help clients manage distress and prepare for processing phases. Session 7 covers EMDR Phases 3–4, focusing on assessment and desensitization. Identifying target memories and using bilateral stimulation helps process trauma, while VOC rating and emotions assessment guide the process. Session 8 introduces the cognitive processing therapy approach. Writing trauma impact statements and identifying stuck points are key steps. Socratic questioning and cognitive worksheets help challenge and modify unhelpful beliefs. Session 9 explores elements of prolonged exposure therapy. Imaginal exposure recounts trauma memories, while in vivo exposure tasks and SUDS monitoring track distress levels, reinforcing learning and practice in real-life situations. Session 10 continues trauma processing with homework review and deepening processing. Continued bilateral work and cognitive restructuring challenge and modify emergent beliefs, reinforcing treatment progress. Session 11 focuses on EMDR Phases 5–6, emphasizing installation and body scan techniques. Positive cognition strengthening and future template visualization help reinforce adaptive beliefs and prepare for future challenges. Session 12 is about integration and meaning-making. Narrative integration connects traumatic experiences to a coherent life story, while post-traumatic growth and values clarification explore personal values and direction after treatment. The theoretical foundation of adaptive information processing explains how EMDR therapy activates the brain's innate processing system, addressing unprocessed trauma that remains frozen in time. Emotional processing theory underlines the importance of activation, habituation, and disconfirmation in trauma treatment. Effective processing requires emotional engagement, leading to significant symptom reduction. The cognitive model emphasizes the balance between over-accommodation and under-accommodation in trauma recovery. Cognitive flexibility is key to developing balanced, nuanced perspectives rather than rigid thinking. The neurobiology of trauma treatment involves understanding the roles of the amygdala, prefrontal cortex, hippocampus, and default mode network in processing trauma and facilitating recovery. Working with dissociation involves grounding techniques, titration approaches, and dual awareness strategies to maintain present focus and manage dissociative symptoms effectively. Incorporating cultural elements into trauma protocols can significantly enhance their effectiveness. By integrating community healing components, we align therapeutic approaches with collectivist cultural values. Cultural belief integration modifies cognitive work to respect cultural frameworks about suffering, healing, and spiritual dimensions. Additionally, modified exposure approaches adapt exposure hierarchies to account for cultural taboos and specific trauma expressions. Addressing complex PTSD requires a phased approach. Phase 1 focuses on extended stabilization, with 6-8 sessions dedicated to safety, emotional regulation, and relationship skills. Phase 2 involves trauma processing, with frequent returns to stabilization as needed. Finally, Phase 3 is identity integration, reconnecting with positive self-concept and rebuilding capacity for healthy relationships. Enhancing trauma protocols involves incorporating additional components. Narrative exposure therapy creates a detailed chronological account of life events, emphasizing both traumatic and positive experiences. Acceptance and commitment therapy uses mindfulness and values-based actions to move forward despite trauma-related pain. Written exposure therapy involves structured writing exercises about trauma over 5 sessions without therapist feedback. Sensorimotor psychotherapy addresses physical trauma responses through body-centered interventions. Compassion-focused therapy develops self-compassion to counter shame and self-criticism in trauma survivors. Addressing comorbidities in trauma therapy requires a strategic approach. The sequential approach prioritizes substance use treatment before trauma therapy, stabilizing acute suicidality. The integrated approach simultaneously addresses trauma and depression through modified protocols, treating anxiety and PTSD concurrently with adjusted exposure. Medication considerations include SSRIs, SNRIs for PTSD and prazosin for trauma-related nightmares, with coordination for effectiveness. Monitoring treatment progress is crucial for evaluating effectiveness. A 65% reduction in PCL-5 scores indicates significant symptom decrease after 12 sessions. Clinically significant improvement is marked by an 8-12-point change on standardized measures. Additionally, a 70% functional gain reflects average improvement in daily functioning and quality of life. Overcoming treatment resistance involves identifying avoidance patterns, such as intellectualization and minimization. Exploring secondary gain helps examine benefits of maintaining symptoms, like support and identity. Motivational interviewing resolves ambivalence about change using ORS techniques and discrepancy. Adjusting treatment pace to match clients' readiness and capacity is essential. Preventing relapse and maintaining progress involves identifying triggers and stress inoculation. This includes categorizing personal triggers, rating severity, and creating specific response plans. Stress inoculation involves rehearsing coping skills under mild stress and gradually increasing challenge levels. Maintenance practice includes daily mindfulness routines, weekly self-guided exposure practice, and monthly cognitive reflection exercises. Research evidence supports the effectiveness of these trauma protocols. The outcomes demonstrate significant improvements in symptom reduction and functional gains, validating the approaches used in therapy. Implementing trauma protocols presents challenges that require strategic solutions. Training requirements involve investing in comprehensive 40-hour specialized training for therapists. Establishing robust supervision structures ensures clinical oversight for complex cases. Therapist self-care is crucial, involving vicarious trauma prevention through coached management and personal support resources. Quality assurance develops protocol adherence measures and outcome tracking systems to maintain treatment quality. To deepen expertise in trauma protocols, specialized training is essential. Joining professional consultation networks provides ongoing support. Utilizing patient workbooks and clinical manuals enhances treatment delivery. Prioritizing self-care protects against secondary traumatization. Exploring implementation science resources facilitates effective agency-wide integration.